what do you do in this context to manage these patients then? If you've got either ESA failure or a person who is not eligible for an ESA, maybe because of their serum EPO level or where they've lost a response, have you tended to go right away to something like lenalidomide as a trial? Have you gone first to HMAs? Can you say a little bit more about that in your practice?
I mean, I think, prior to luspatercept, I absolutely agree there was a really large unmet need, and there's still, of course, unmet needs in this disease space. But I think in 2024, we're certainly making a lot of progress. So, even though it is an off-label use in my ESA failure patients, my next line of therapy is generally luspatercept. Even though COMMAND's eligibility criteria included a serum EPO of less than 500, I feel like that was really kind of included to level the playing field a little bit for a homogeneous group of patients to compare to epoetin alpha. So I think even for a patient whose serum EPO was greater than 500, I personally, in my practice, may still consider a trial of luspatercept. Just, I think weighing, that it has a favorable toxicity profile and it's easy to administer.
Yeah, I think the big changes that we've seen over the last 2 years in lower risk MDS, you alluded to one, we can pick these patients out much better. Yeah. So with molecular diagnostics, we really should be sequencing everyone when we make a diagnosis of MDS, and we are much better at identifying those patients who are going to coexist with MDS for years, and they're going to need multiple therapies throughout their lifespan with that disease. So being able to identify them is step one. But then we have had a number of major studies in the last 5 years really changing the treatment options for these patients. And I think that to the point that you bring up, suddenly we have agents that fill that gap, that fill this kind of space where you were jumping either from growth factor or chemo. And now we have agents that we can be using in between. I like also, for instance, combination type data. And so one of the bigger studies that came out, for instance, was even just challenging this use of ESA as your first line agent. And so we talked a little bit about commands, but thinking, is EPO the best agent for every patient who walks in the door? Or can we be more nuanced perhaps about what we're trying to achieve with patients? Also thinking about this lifespan question, we unfortunately have let people really drift down into pretty severe anemia before we've ever tried to intervene. And are there ways that we're kind of rethinking that now? Should we be waiting so long? Are there detrimental cardiovascular or other side effects of coexisting with pretty moderate anemia, maybe on the cusp of transfusion dependence, but not quite there? And what does that, how much does that impact people's livelihood, the activities that they do? So I think that there are some really big changes that we should be incorporating in our practice. And one of the areas where I think we're still learning how to use all the data is from the COMMANDS trial. Yeah. So that trial, again, randomized patients 1-to-1 with lower risk MDS. They had to have some transfusion needs, so 2 to 6 transfusions in the last 8 weeks, but randomizing them to luspatercept versus epoetin alpha. And we've seen a lot of this data over the last 2 years as it's become kind of better understood and subgroups have been understood. But really what you see is that both these agents are effective, but there are more people who benefit when you give an upfront strategy with luspatercept, and that's particularly in patients with ring sideroblast disease. And I think that that's probably the biggest impact on my understanding of this. Again, I really want to be able to provide treatment for as long as possible for these patients. Ring sideroblast status may give us a little sense of the magnitude of that benefit between patients, but it's expanded the lower risk options so that you don't have to jump to chemotherapy, and I think that that's a big shift that we've done.
I really like that you brought up the point about kind of when we intervene in these patients. And, again, if you look at COMMANDS, of course, it required transfusion dependence. I think if you look at some of the real world data in terms of use of these agents, a lot of us are starting them kind of before patients reach that threshold of needing transfusions. That tends to be my practice. And I think, with sort of the updated label for luspatercept, for example, in patients who may require transfusions, if you look at NCCN guidelines, it references actually symptomatic anemia. So we have had, I think good luck being able to treat our patients prior to, needing that, what I consider to be a rescue therapy of transfusion support. And I think if you look at some of the data, it suggests that targeting a hemoglobin of around 10 or higher probably correlates with, the best quality of life and the least symptoms, although I think that's a highly, individualized number depending on your patient. But I think those are great points that you brought up.
Yeah, no, I mean, it is interesting, and in the end of the day, you're sitting with a patient and you're trying to figure out what makes sense. And for instance, in Boston, nobody wants to drive into the city. Right. So I am often waiting until people are coming in at least once a month, and they have enough of a clinical burden already by seeing me to institute something. Often that does correlate with transfusion needs. I will say that once you're coming in once a month, I might be more apt to use erythropoietin-stimulating agents. There is some interesting data about that, actually from this year's ASH as well, a French study trying to compare early intervention versus not a later intervention of EPO agents. And it kind of falls into a line where you can get more improvement in hemoglobins, but you're maybe not affecting the natural course of disease. And so can you... So I do think that there is this role of trying to titrate individually with the patient my clinical burden with the therapies available. And then, I think that our goals overall should be to free people from their need. One thing that's not been really studied that I'm interested in, I've had a number of patients who respond so well that I've had to delay them. Mm-hmm. Yes. And instead of dose reduction, I'm often giving them more time away from my clinic.
Injections, yeah.
And that allows them to travel, that allows them to do things. And I know it's not been, I'm hoping that maybe that's a rigorous study that we could do eventually. But I think that the ability for flexibility in dosing and understanding that we have multiple agents is something that is the main message of low-risk MDS in 2024.